Okay, welcome everyone to 2021 and our new OSHR Collaborative Director Series. I'm Dr. Melinda Ring. I'm the Executive Director for the OSHR Center for Integrative Medicine at Northwestern University. And this year, one of the benefits of having virtual grand rounds is that we can draw on our colleagues from across the world to come and share their knowledge. So we've asked directors from the 7 OSHR centers in the OSHR Collaborative to come on a monthly basis and lead us in an integrative medicine grand rounds, sharing their own expertise. And I invite you to save the dates. Next month, we have Martin Ingvar from the Karolinska Institute in Sweden, who's been doing some remarkable work around healthcare delivery and how integrative approaches help. Ruth Wolliver in March from Vanderbilt, who's an expert in the health coaching movement, and Dr. Robert Schwartz from the University of Miami, one of our newer OSHR centers. And then these will be followed by UCSF, Harvard, and the University of Washington. So again, I invite you to make sure you're signed up for the future webinars. I am also going to give a little shout out because today we have our announcement going out for our faculty fellowship in integrative medicine. The applications are opening for the start of the year that begins in July. This is a year-long fellowship program for MDs and DOs across Northwestern University and the other OSHR centers that allows them to add integrative medicine into their existing practice and then be eligible to sit for the ABOIM board exam. And you can see here our current class. We have a great cohort. We meet weekly. It's very fun. They're learning a lot, so I hear. And so please look out for that application if this is something you're interested in. And you can contact our manager, Isra Hassan, for more information. And with that, I'm going to jump into our grand rounds. I will just say logistically, if you have questions, please put them in the Q&A and I'll try to get to them at the end. Or our research assistant, Veronica Grote, is in the chat also, and she'll be able to answer any questions that might come up. So please post those in the Q&A and I'll get to them at the end. All right, so today we're talking about culinary medicine and the science of the teaching kitchen. And really, you know, amidst everything that's happening in the world today that emphasizes divide and differences, one commonality remains true. Every living being on the planet needs nourishment. Today, I'm going to share with you what I think is one of the most exciting innovations in medical education, that of culinary medicine. My hope is that after seeing some of this data, you're going to have a greater appreciation of how critical nutrition is to health and why we need to find innovative strategies to bring this content to all health professional schools. I don't have any conflicts of interest related to this presentation. In terms of what I'm hoping to cover, we'll distinguish between teaching kitchens and culinary medicine and their respective role in nutrition education, the link between diet quality and health and the related role of a health professional, the current gaps in nutrition education and health professional training, and then potential solutions, again, focusing on a program that we developed here at Northwestern called Cooking Up Health. So what is culinary medicine? The term culinary medicine's been co-opted by chefs and foodies and influencers, but today we're thinking about it as a medical intervention with the intended goal of preventing and treating disease. Dr. John LaPuma defined this rapidly growing field as a new evidence-based field in medicine that blends the art of food and cooking with the science of medicine. And in this way, we're moving beyond basic nutrition knowledge and really adding practical culinary approaches to assist patients in achieving and maintaining optimal health. So health professionals who practice culinary medicine are shifting from this reactive therapeutics to really a more functional root cause approach where nutrition and healthy food preparation take front stage. It's also a team-based approach, and it's adding a new partner into what we see here as one of the more traditional medical teams, and that is that of a chef instructor. Now, teaching kitchens, on the other hand, could be described as learning laboratories for life skills. So while teaching kitchens can be increasingly found in hospitals and clinic settings, they can also be a part of a school or a community organization. They could be a pop-up with just some cutting boards and knives, or it could be a full, beautiful, equipped, built-in kitchen. Family Cook Productions, which is an organization that helps implement these teaching kitchens, lists the following as fundamental things that happen in a teaching kitchen. So the first one is nutrition education. So that's about nutrients in food, how they support health, how to compose a balanced meal, hands-on culinary instruction and practice, meal planning strategies, and really, again, making this very personalized to what somebody's resources are, what access they have, and then uniquely some goal setting and group support that addresses barriers and where people who are in the group can share successful strategies. This model of education is being used across the country in diverse populations. You can see here kids in common threads doing some cooking. This middle one is a great program called Teen Battle Chef. It's being implemented in colleges. This is from UCLA, a course for their undergraduate students. And of course, patients. So in the Northwestern system, for example, Kish has a beautiful kitchen that offers drop-in classes. MedStar and Cleveland Clinic are examples of health systems that have shared medical appointments around culinary medicine. And then there's also things happening in the workplace for staff. And, the one on the top here is just a pop-up kitchen where people get cutting boards. But in the bottom, you can see Google's, where they actually have, no surprise, a very high-tech teaching kitchen as a perk for their employees. And then, what we're focusing on today, healthcare trainees and healthcare professionals. And again, that's going to really be the focus for the rest of my talk. Now, this culinary medicine and teaching kitchen movement has really taken off over the past 5 to 10 years. The major driver for this is just the indisputable fact that nutrition is related to chronic diseases, including heart disease, cancer, and diabetes. And these chronic diseases are the leading causes of death and disability in the US. 6 out of 10 adults in the US have chronic disease. 4 out of 10 have at least 2 chronic diseases. And in the COVID-19 pandemic, you've probably seen in the news that chronic disease and obesity are not just comorbidities for infection, but are linked to more severe negative outcomes from the virus. In 2018, the US Burden of Disease Collaborators published an updated list of risk factors influencing disease burden in the US population from 1990 to 2016. And you can see highlighted in red here, dietary risks were the #1 risk factor for premature death, and in the bottom chart, #3 for disability adjusted life years. And that's separate from other risk factors, including things like elevated body mass index. So it's not just weight, it's really diet quality that makes a difference. What about globally? According to the 2019 Global Burden of Disease study of 195 countries, dietary factors are the single leading cause of death, exacting an even greater health burden than smoking. And they stated that improvement of diet could prevent potentially 1 in every 5 deaths globally. So what are those dietary factors? Well, the Nutrition and Chronic Disease Expert Group completed systematic reviews and meta-analyses to estimate the associations of specific dietary factors with mortality due to heart disease, stroke, and type 2 diabetes in US adults. And based on a comparative risk assessment model, they estimated that over 45% of all cardiometabolic deaths were due to suboptimal intake of 10 foods and 7 nutrients. And those included protective effects of fruits, vegetables, beans, legumes, nuts, seeds, whole grains, fish, yogurt, fiber, seafood, omega-3s, polyunsaturated fats, and potassium. And then the harms of unprocessed red meat, processed meat, sugar-sweetened beverages, glycemic load, trans fats, and sodium. Our new 2020 to 2025 dietary guidelines for Americans, which came out recently, you can see here the advisory committee report, and this included a chart here which showed that these dietary patterns that we're discussing, or that I just described, are not only associated with cardiovascular disease and all-cause mortality, but also things like varied cancers like colorectal cancer and breast cancer, bone health, and very hot right now, neurocognitive health. So given that we get these guidelines every 5 years, how healthy are we? How are we doing? Well, the Healthy Eating Index, or the HEI, is a measure of diet quality used to assess how our intake as a country aligns with these key recommendations. If we have an overall HEI score of 100, that suggests that the set of foods being reported by people is in line with the dietary guidelines recommendation. In our 2015 score for Americans, we had a pretty poor showing. It was only 59. On the right, you can see that older Americans, or those age 65 and older, had the highest diet quality at 66. And I think very concerningly, children who were in the 6 to 17 range had scores that were lower than the population average. And, of course, unhealthy children are at much greater risk for becoming unhealthy adults. When we look at where is this dissonance, why isn't our HEI score 100, and we look at it by food group, we can see that overall intakes in our country of fruits, vegetables, and dairy fall low relative to the blue line, which is the recommended amount, while grains and proteins, which in our case includes refined grains and things like processed meats, are too high. And from 1999 to 2016, despite what seems like a gluttony of media and press about nutrition, the overall average healthy eating index of US adults across the board has remained in the 55 to 58 range. We have not made significant improvements over the past few decades as adults. Now, what about for kids? So it's a little better here. We can see in the orange line here that the overall estimated diet quality of US youth showed modest improvement, with declines in the number of the percentage that were rated as poor quality. But still, when we look at the 2015 to 2016 rating, less than half of youth are still having poor diet quality. So given the preponderance of evidence that links poor diet to premature death and chronic disease, there are calls across the healthcare field for nutrition to play a larger role in the provision of healthcare. A recent 2020 call to action listed several key actions, ranging from things like food as medicine interventions like VeggieRx programs. We have some of those in the Chicago area, research, equitable access to healthy food. And then number 4, I'd identified what I'm going to focus on again for the remainder of the talk. What is the role of the clinician, and how can we better educate those clinicians in order to help our patients? So let's shift again to the role. And I'm specifically going to focus, even though all healthcare providers play a role in this, the data I'm going to share today is really on the role of the physician in nutrition counseling. So, nutrition and disease relates to many factors: food scarcity, the food choices, micronutrient deficiencies, energy imbalances. The data I'm going to show now is on the role of physicians in screening, diagnosing, and treating obesity. So we'll look a little more closely at that data. Now, obesity is, of course, multifactorial. There's macro level forces, there's socioeconomic and environmental drivers. We have genetic influences that relate to obesity. But in a patient visit, physicians have the most likelihood of impacting that inner circle related to behaviors, diet, choice around physical activity. And so the question is, do health professionals and physicians in that healthcare visit, is it worth them taking the time to counsel patients about nutrition? Will it actually make a difference? And it turns out that yes, clinicians do and can empower their physicians to make health promoting behavior changes. This meta-analysis of 12 studies looked at physician weight loss advice and then actual patient weight loss. And it found a positive association across the board, regardless of the population studied, regardless of whether the physician provided really advanced counseling or just simple recognition of overweight obesity with recommendations to lose weight. And in 2014, an analysis of data from the National Health and Nutritional Examination Survey, the NHANES, found that overweight and obese patients whose doctors spoke to them about their weight were twice as likely to lose at least 5% of their body mass over the following year. And despite major guidelines, really from just about every major organization that recommends that physicians counsel overweight and obese patients about weight loss, a survey, this one was done in 2008, showed that less than half were tracking body mass index or providing nutrition education. So this was back in 2018. Are we doing any better since then? Well, a bit, but only if you were obese, not if you were in the overweight category. This was a survey across 5 health systems in the mid-Atlantic region of the US. They were surveyed in 2015. And again, less than half of overweight patients received counseling, but if they were obese, that number went up to 63%. When physicians have been asked why they didn't counsel patients about nutrition, and this is a survey, a study that was done of physicians in a hypertension population, physicians reported different things. They reported lack of knowledge, lack of confidence, lack of time, lack of trust. And then they self-identified 3 solutions that they felt would increase their rate of counseling. The first was to have tools readily available in the electronic medical record. The second was to have more easy access to referrals for dietitians. And then the third was more nutrition education and medical training. So they had more confidence and would feel more confident providing nutrition advice to their patients. So what's the current state of nutrition education? Well, the bottom line is it is not very appetizing. The most recent survey of US medical schools by the National Academy of Sciences found that only 29% of medical schools provide the recommended 25 hours of nutrition education, with an average of 19.6 hours total across 4 years. And a lot of times that education may be around inpatient nutrition and not necessarily relevant to the community at large. And recent medical school graduates that were entering a pediatric residency, these are the doctors who are going to be counseling parents and kids about nutrition, scored a failing score of 52% on a very basic nutrition test. And it's not just pediatrics. This was a cross-sectional survey of interns that looked at internal medicine, general surgery, and OB-GYN. 71% of those interns felt unprepared to address the nutrition needs of their patients. And sadly, they weren't wrong. When they were given an exam, they, again, failed these basic knowledge questions about nutrition. This red flag, that we have about inadequate attention to nutrition in medical school is really being given attention across the globe. We've got our colleagues to the north in Canada. We've got the UK studying this, all across Europe, international surveys. Problems in Japan showing a lack of adequate nutrition education. In the United Arab Emirates, our Australian colleagues, our Portugal colleagues, and in Africa, all of these countries reporting, and again, a systematic review, then bringing it all together, saying there were 24 studies conducted from 2012 to 2018 and concluded that nutrition is insufficiently incorporated into medical education, regardless of the country, the setting, or the year of medical education. Now, what about continuing medical education? Are there conferences available that can help doctors catch up on those nutrition needs? Well, a survey that was done of cardiovascular conferences, which is a field we'd look to as perhaps having the highest recognition of the role of diet in disease, had no increase in time devoted to nutrition from 2013 to 2018, even though, again, there is this growing evidence base. Here's an example of a typical cardiovascular disease symposium, 15 minutes over 3 full days devoted to the role of nutrition in cardiovascular disease. So, on the upside, there's a lot of opportunities for innovation in medical nutrition education. And we need to think about the possible solutions, and we need data on what is most effective. Where is the context? When should this happen? Should this be mandatory or elective? Is it best done as a lecture, as bedside teaching, online courses, community service? What we've chosen to do, and what I'll talk about next, is the role of, again, culinary medicine as nutrition education for students. And then what is the best timing? When should it happen? And, I think the reality is really throughout somebody's career, starting from undergraduate medical education and then going forward. Now, going though from those later times, there are a growing number of continuing education conferences devoted to teaching health professionals about food as medicine. One coming up, and one that I've attended a few times, is the Healthy Kitchen, Healthy Lives Conference. That is a collaboration between the Culinary Institute of America and the Harvard School of Public Health. It is a great conference. It is sadly going to be online. I'm sure there will be still great education this year, but very fun to go in person and get to taste all of the good food in Napa. But really, there is a growth in nutrition education for continuing education. And those are a good stopgap and something that I encourage really all doctors to attend. This is an example of perhaps one that's a little less accessible, but in this case, the participants were first taught concepts of culinary medicine. They did an online 16-week course about Mediterranean diet, and then they went for 2 weeks to Tuscany, Italy, where they got culinary lessons and went to organic farms and got to taste authentic Mediterranean foods. And post-immersion evaluation showed that these did improve nutrition knowledge and self-efficacy. I think this is perhaps a great model, but maybe not accessible for our large population of health professionals that need training. And so now, stepping a little earlier, what about residence and fellowship? It's a little harder with the fellows and residents. They're rotating every month through different rotations, some of which are very intense and others which may be lighter electives. So the timing can be a little more challenging. In this study, they did pilot taking preventive medicine residents, doing 3 training workshops that were facilitated by an MD chef to provide both culinary and nutrition skills. And then they taught 2 community members. This did lead to self-reported improvements in cooking competency, and the trainees reported that they had a greater belief that lifestyle medicine would impact patient behavior. The greatest amount of data so far is in the undergraduate medical population, and much of this really was spearheaded by Tulane. Tulane University was the first academic institution with a full-fledged teaching kitchen, the Goldring Center for Culinary Medicine, and under the founding director, Dr. Timothy Harlan, they created a multifaceted curriculum that has since been adopted in full or in part by many different health schools. This study that they've created is called CHOP, medical students. CHOP stands for Cooking for Health Optimization with Patients. It is the largest multi-site cohort study to date. There were over 3,000 medical trainees from 20 medical schools who completed surveys, and their analysis showed that hands-on cooking and nutrition education compared to those students who just went through the traditional medical school curriculum had significantly improved nutrition competencies and med diet adherence. So this type of work from the Goldring Center has really been instrumental to the growth of culinary medicine. And this Goldring program inspired our team at Osher Northwestern. We did consider using Tulane's curriculum, but realized that we wanted a program that was a little more congruent with integrative medicine approaches to nutrition, focusing in a culinary sense solely on plant-based nutrition. And we also wanted it to incorporate a strong emphasis on immediate community impact and service learning. So to that end, we developed a partnership with the nonprofit organization Common Threads. Common Threads provides hands-on cooking and nutrition education for children and families in underserved communities. We've been great partners. We have, as you can see here, a lot of synergy in our missions, and we continue to work together on this culinary medicine program. So together we came together, we envisioned this culinary medicine curriculum for medical students where they would apply their knowledge at public schools, thereby potentially impacting not only their own learning and their care of future patients, but the health of the kids that they worked with on a day-to-day, on a regular basis. We were fortunate to receive several academic community research partnership grants that helped support our work in the early years. So to briefly describe the course, it consists of 6 culinary medicine sessions where the students come into the kitchen with faculty, with a chef, and learn both about nutrition and then do hands-on cooking. And then interspersed with that are 4 community sessions where they go into the Chicago Public Schools and teach children, grade school children, about nutrition. You can see here that each of the culinary medicine lessons, we created content related to nutrition, applied nutrition, diet for disease prevention and management, public health, nutrition coaching, cultural cuisine, and of course, culinary skills. And this is an overview of just the big features of each lesson plan and how they fall into those. You know, we incorporate motivational interviewing, goal setting throughout, cultural competencies, public health things like food access and the environmental impact of dietary choices, and then different disease focuses as well across the different lessons. And moreover, those learning objectives are closely linked to core competencies such as community, communication, and system-based care in the Feinberg Medical School. Now, when we originally piloted this, the students came and we would lecture to them before going into the kitchen, and you know, sometimes their eyes would glaze over. This was in the evening after a long day of already doing a lot of education. And so what we ended up doing was figuring out we wanted to keep our students as engaged as possible. And so to that end, we went into more active learning techniques. Of course, going into a kitchen and cooking is already an active learning technique, but we really wanted to think about how can we incorporate as much engagement and active learning as possible. So now what we have them do is we've created a series of videos that they watch before coming to class where they get to do the more didactic session on their own, so that when they do come to class, everything is active. And this includes different things. It includes, of course, the cooking, as you see on the right. And then on the left, you can see that the students over dinner have discussion. We have student-led article discussions where they review some pertinent nutrition literature and critique it. And then, of course, we have them engage in coaching where they pair off and use patient scenarios to practice coaching each other. And then these sorts of skills are all brought together when they go into the community, into the Chicago Public Schools, to administer this Common Bites, which Common Threads created. It's an established grade school nutrition curriculum, and they teach the students. Now our pre and post assessments are in 3 categories. We look at their own medical student dietary intake, their attitudes, and confidence around cooking and nutrition, and their confidence in nutrition counseling. And we've seen, significant increases in both confidence in doing basic nutrition and obesity counseling in students who have participated. Here you can see, again, trends going up in both. And what about their own cooking skills? Of course, those also went up. This includes their confidence in things like planning meals. We also found significant increases in their own fruit and vegetable intake. And, these sorts of things are really important. This is part of why we wanted to have this course, because of course, medical students we know have a lot of stress. Their own taking care of themselves makes a difference given the high pressure and risk of burnout during training. And so the more that they can incorporate these health promoting behaviors, the healthier they will stay mentally and physically. There's a lot of other outcomes. We've presented this, we've published an article. With Common Threads, were awarded the 7th Annual Community Engaged Research Partnership for exemplary partnership. And, we're very proud of the course and the impact that it's having. We have also, with Common Threads, hosted 2 Train the Trainers to help disseminate this across the country. We have thus far had 14 institutions across the country with 25 attendees come to learn about cooking up health so that they can bring it back to their own institutions. Now, what about during COVID? So, during COVID, of course, going into a kitchen as a group, going into classrooms in the Chicago Public Schools was no longer an option. And so we had to go virtual. So halfway through our spring 2020 elective, our students had done 3 in-person classes, and then they switched to 3 virtual lessons. They enjoyed it. They felt like they learned a lot. And then after discussion with the medical school, our Cooking Up Health team worked to transition the full course that normally takes place over a semester into a 2-week elective. This required adding on 4 additional classes. And to these, we added culinary medicine for the underserved, nutrition and COVID, culinary and medicinal herbs, and micronutrients. And then over the summer, we went live with 2 groups of students, this time having them do the asynchronous learning where they would watch the videos, do online quizzes and assignments, and then meet synchronously with faculty several times over the week, both doing 4 live cook together sessions ahead of time, where I was in my kitchen with 2 cameras set up so I could demo cooking techniques, and then the students all cooked along in their own homes to prep a plant-based meal. We had synchronous sessions where the students did a debate over Zoom, things like that. So again, trying to make it as engaged as possible. So of course we were curious, how is this experience going to stack up? Since one of the favorite parts of our original course was being able to cook together and then relax over the shared dinner. And our preliminary analysis and student feedback shows that virtual CUH was a success. Again, consistent with the previous years, students were reported increased confidence in their ability to provide nutrition and obesity counseling, increased confidence in their cooking and food prep skills. And they were able to stay engaged with it being virtually. And one of the most interesting things that we found also was that they said that they felt they were more likely to cook because now they had had the experience in their own kitchen preparing a full meal. So we're going to continue to offer both for now, the virtual and then the in-person course. We also, I just want to share with you, we're featured in this national documentary by the Take Care campaign in this video called Cooking for Life. And because I can talk a lot, but seeing something in action is always more effective. I'm going to show you just a cut of this for a couple of minutes so that you can see really what happens in a Cooking Up Health course.
Make the choices you do.
If you're eating healthy but you still don't like the taste, you're not going to eat as much as you need it. Kanya is my instructor for small bites. Being able to work with a medical student is really cool because we both are learning something new at the same time.
On both sides of my family, I have predisposition to diabetes, heart disease, cancer.
It's also
I chose to take the class in culinary medicine to learn how to eat healthier myself.
Oh yeah, that was a sweeter smell. I like that.
If I make a change now and really eat healthy, I can prevent myself from getting these diseases or prolong how long I can live without them.
In our neighborhood, there's a lot of junk food and not much healthy food, and that's a problem. The doctor told my mom and my grandma to modify their meals.
It was like, boop, boop, wake up.
Learning about simple recipes gave me more confidence to be able to do it by myself. Okay, so I have the list. Spinach, chicken, frozen vegetables, and...
I have to take the drive to get to the good grocery store, but I'm learning that healthy food is going to cost you if you buy it now, or it's going to cost you when you go to the doctor. So you decide.
I think if I had had a class like Peyton has when I was, in 7th grade, probably would have had a pretty big impact on the choices I continued to make as I grew up.
I feel like my sister is more likely to eat healthier food if she helps prepare it. It's done. I'll give you some extra salad. Being able to give them something that I prepared for them, that was really fun. They actually enjoyed it.
Our forefathers and mothers didn't have access to health care. They had to use what Mother Nature offered. And it's really exciting to know that the medical field is now seeing that we are our own first health care provider.
So there's a longer cut if you're interested in going to see that. And I'll just close with this quote from a systematic review about nutrition and medical education. Says, despite the centrality of nutrition to healthy lifestyle, medical students are not supported to provide high quality, effective nutrition care. Medical education can be enhanced by institutional commitment to make nutrition education compulsory in medical training, the establishment of nutrition competencies to provide a benchmark for nutrition knowledge and skills to be included in curricula, and supported by funding for innovative curriculum initiatives. These initiatives will improve nutrition and medical training to support future doctors for the 21st century. And with that, I also want to make a few acknowledgements on the right, our funding support. So the Greer Foundation is a generous supporter of our growth and what we hope to do to scale up Cooking Up Health to impact more students and more kids in the community. The Weil Foundation, the Osher Foundation, ARC, New Cats, and our own I'm Aware Philanthropic Council. All of these have helped support the production and provision of Cooking Up Health. And then an acknowledgement of some of the core members of our team, with a special shout out to Elaine Chung. Elaine, our PhD, has been core to all of our evaluations and the development, and she is sadly for me moving on to a new role, but we wish her the best. And then also special thanks to Rupa Mahadevan, one of my original co-creators, and Amreen Gauss, my current fellow, who helped with the transition to virtual medicine, and Stephanie Fokins, who's our lead person at Common Threads. So thank you. I'm gonna turn off the screen and see if there's any questions that I can answer, and feel free to pop them into the Q&A also. Okay. Can you restate your pre and post course education tools? So the pre and post assessments that we did were in 3 categories. Again, the first one was about dietary intake, and this used something called the Prime Screen Dietary Screening Tool. This again was to measure the medical students, not the kids, personal intake in different food categories. We did modify it to include more plant-based food, since that was the focus of the course, and we wanted to see if they were including more plant-based proteins and other things in the class. The second major category was that of cooking and nutrition confidence, attitudes, and behaviors. There are 3 measures we use there. One is the Cooking with the Chef Cooking Attitudes survey, one is the Cooking and Food Skills measure, and one is the Cooking and Eating a Plant-Based Diet measure. And then the third was Confidence in Nutrition Counseling. Again, 3 different surveys we use there: confidence in providing basic nutrition education, confidence in obesity counseling, and then one about attitudes called Attitudes Towards Counseling Patients in Nutrition Care. In addition to those kind of more standardized surveys, we also included different qualitative questions about engagement, about how this is impacting their current, when they see patients right now during medical school. Are they counseling more? We got a lot of exciting answers that even first-year medical students were incorporating this more. And we've also done follow-up surveys 1 or 2 years post-out, showing that they were continuing to have positive attitudes towards nutrition in patient care. Okay, another question was expertise specific to tools. Okay, so a question about foods for a toolkit for oncology care or specific cancers. So that is not a major part of what we don't have a special oncology unit. I think there is a lot of debate about different approaches to oncology care. I think in all cases, when we're talking about I think the one thing that we know is red meat, not good for cancers. you know, we do not have a toolkit that we teach the students about that. You know, certainly in our integrative medicine practices, we do talk with our cancer patients about nutrition and the role. But I don't have a toolkit. I think there are some great resources, some great books available about nutrition and cancer. One of our sister centers, the Osher Center for Integrative Medicine at UCSF, has actually collated a wonderful resource on, since they have a whole integrative oncology team there. If you go to the Osher UCSF site, they have a specific nutrition and cancer list of resources. So I'd encourage you to go there. Yeah, so that's what I would recommend. If there's any other questions, I'm happy to take them. Otherwise, we may finish a little bit early. And we will be posting the full recording on our website. If you needed to go back or if you wanted to share this with other people, you can go to the Osher NU Northwestern University site, where we have as many of the recordings of our past grand rounds as we can. And we, again, also have our future ones. There's a question, do dietitians help with your course? The dietitians have helped with the course. One of our Osher dietitians helped create a meal plan for the medical students over 6 weeks, because of course, knowing how to batch cook, knowing how to repurpose meals is an important thing. Common Threads also has dietitians that help with nutrition with some of the meals that we chose and other sorts of things. They don't participate in the regular teaching of the class. We do, of course, teach our medical students that, you know, the goal is not that they're going to become dietitians, nutritionists, but really they get the starting knowledge, they get the confidence in order to provide, again, basic nutrition counseling and obesity counseling. But medicine has to be a team-based, especially in the area of nutrition. And so knowing how to get started and then how to refer to experts within the system or in the community is important.
There was an additional question in the chat. Do you know of any public school systems you know of that have a budget for this sort of teaching?
So, you know, the answer is the public schools, for example, when they use Common Threads curriculum. So Common Threads is in many, really many schools across the city and in multiple states across the country. So our students help teach it in, you know, one school, but the Common Bites curriculum is very widespread. These are oftentimes supported by grants from different corporations, from insurance companies, and schools do get grants so that they can offer this into Chicago Public Schools or other schools. Okay. Well, with that, I think we'll close. We'll let everybody get on with their day. Again, look out for future ones, future Osher Director Grand Rounds with our Karolinska partners coming up next in February. I'm really looking forward to it. I will see you then. There will be a replay at noon if you know anybody who wasn't able to make it this early in the morning and wants to come back. So have a great day. Thank you.